Thank you for having me. It's been a great course so far. And so we'll switch gears a little bit. We've been talking a lot about implants, inner bodies, techniques, screws. So let's switch a little bit to osteobiologics. Here are my relevant disclosures. Notably, I am a consultant for Bioventus, so you will see some of the products represented in the presentation, but try to keep this as unbiased as possible. As far as for what we want to get out of this talk, I wanted to describe the different classes of osteobiologics available for minimally invasive techniques. Important in that is also reviewing the current literature regarding outcomes of osteobiologics. And I think in addition to looking at the outcomes of the different studies is to get an appreciation of how to critically assess what a particular study is trying to display, because there's a lot of heterogeneity over how you assess fusion status, things like that, in these types of studies. So why should we care about osteobiologics? Well, at the end of the day, we're talking about fusion surgery. So arthrodesis is our primary goal. And really, this is critical for your durable long-term outcome with these types of surgeries. I think a lot of people have noticed that when you talk about minimally invasive spine surgery, you're really talking about surgery at the disc space. And so, in contrast to open surgery, our burden of arthrodesis is primarily within the inner body space. Now, there are some variations where people will do some decortication either through like a small incision, or they'll drop a tube over a percutaneous screw, rough off the facet. But that's not the same in all MIS surgeons. So there's a number of surgeons, myself, I consider myself in this category where I don't really do any posterior lateral arthrodesis if I have a inner body in place. So really we're putting a lot of stress of burden of fusion within the disc space. And so what kind of biologics, but also what kind of techniques you're using to get this arthrodesis are important to pay attention to. So what are the biologic properties that promote arthrodesis? So you'll hear these terms often: osteogenesis, osteoinduction, and osteoconduction. So what do these exactly mean? And I think this is especially important for the neurosurgeons in the audience because, I think with our orthopedic colleagues, they have the benefit where they treat a lot of fractures. I think bone biology is a lot more well taught in their training paradigms, whereas as neurosurgeons, this kind of becomes almost like a secondary or tertiary topic. So I think since we do so much spine surgery, this is something that's important to understand the biological cascade for bone healing. So what does osteogenesis mean? So this is talking about the synthesis of new bone cells derived either from the graft or the host. Osteoinduction. This is the process by which mesenchymal stem cells are recruited to differentiate into chondroblasts and osteoblasts. And the newly formed osteoblasts are responsible for the bone formation. So this is an important step. Osteoconduction, also important. So this is a process by which capillaries, perivascular tissue, and mesenchymal stem cells form a scaffold along the graft. So scaffolding is something that you'll hear a lot talking about the osteoconductive properties of different grafts that are available commercially. And so ultimately, this is going to result into the fusion of the graft with the host local bone. So again, that's the name of the game here. So the functionality of bone grafts in promoting spinal fusion is largely dependent on the graft's ability to perform any of these three processes. And we don't have to put the onus of this just on the graft itself. There's other supplemental things that you can use if one particular class of graft doesn't have all of these properties. But I think this is an important framework to think about when you select whatever biologics you're going to use for a fusion, that you cover all three of these pillars. So as far as for an overview of bone grafts, and again, this is a very kind of more of a top-level overview. We're trying not to get too much in the weeds here since the time is limited, but just as an overview. So autogenous bone graft. So really, this is the gold standard when you talk about arthrodesis. So the old-fashioned iliac crest bone graft. You have osteoconductive, osteogenic, and osteoinductive properties. And the advantage here is that you have complete histocompatibility, and it promotes a strong fusion, and really is the only graft that has all three of these pillars in the spinal fusion. Disadvantages are the quality of the graft is dependent on the patient. So especially in the degenerative population, you have patients with osteoporosis, patients with poor bone quality, if they have other comorbidities. So your graft is only as good as your patient. And then in particular, and I think this is probably the primary driver for why, even though the biologic properties of autogenous grafts, where the use has fallen off, is really the local pain at the extraction site. So that's a big minus. Bone marrow aspirates. So in theory, these aren't osteoconductive, but they are osteogenic and osteoinductive. The advantages is their minimal donor site morbidity. Usually you can aspirate this through a gym sheet or a large bore needle. Disadvantages is this has to be incorporated with some sort of scaffolding, so you're talking about an allograft. So we get into the different allografts. So allografts, they're osteoconductive, osteoinductive, but they're not osteogenic. The advantages are they lack donor site morbidity, which can be and then can be combined with mesenchymal stem cells. The disadvantages are these allografts require sterilization, and then the process of the sterilization can actually alter the biomechanical properties of the graft itself. Demilitarized bone matrices is another type of allograft. So again, osteoconductive, osteoinductive, but not osteogenic. You have similar advantages as the allograft. And then additional disadvantages, you have lower rates of fusion than autogenous grafts. You might have a higher rate of spinal collapse, and this suffers from possible contamination during the production process. So something to keep in mind. So getting to the next class, you have ceramics. So these are osteoconductive, but they're not osteogenic or osteoinductive. They can be, you can supplement with the osteogenic growth cells and growth factors from an autograft or something like that. And these have a relatively long shelf life, so you don't have to worry about any of the processing characteristics here. They can sit on the shelf. Disadvantages is the lack of the cortical stability and the osteogenic properties. So generally, this is something you have to use in combination with something else. And then a newer class of bone graft is that's actually quite popular, but we'll get into some of the data here, is the allogeneic cellular bone matrices. So in theory, these have all three pillars. If you look at what is purported to be the case in these grafts, so you have osteoconductive, osteogenic, and osteoinductive activity. Theoretically, you have all three pillars, and you have similar advantages to the different allografts, where you don't have to worry about donor site morbidity, things of that. The disadvantages are the production is proprietary, and that a lot of the true cellular content and activity is really unknown in these products. So that in itself wouldn't be as big of an issue, but these grafts are associated with higher costs, and we'll kind of get into this in a little bit. So that's something to be aware of, I think, when you're evaluating these types of products. And then in addition to the bone grafts, there's also the supplements. So famously, bone morphogenic proteins in particular. So these, the mechanism here is with the TGF-beta family of cytokines that initiate the SMOD pathway for activating transcription factors for growth. So the advantages are you enhance osteogenesis and osteoinduction. Disadvantages, if you use this at supraphysiological levels, these can be antagonized by BMP inhibitors. And so that's something to be important to realize. And then finally, just high cost associated with some of the products here. Mesenchymal stem cells, theoretically, this is another graft supplement that can be used. So you differentiate. So the mechanism here is they differentiate into osteoblasts and chondrocytes in theory to promote spinal fusion. You can create a graft with all three properties of osteogenesis, osteoinduction, and osteoconduction if you couple this with an allograft or a DBM, let's say. But the disadvantages is potentially there's some chronic harvesting site pain here. Really the evidence for this type of technique is not great. And finally, we can talk about synthetic peptides. There's some newer products on the market here. So the mechanism here are an amino acid sequence found in alpha-1 chains and type 1 collagen that enhances bone mineralization. So the example here, the fusion rates of I factor is one of the examples here, compared to autograft, were slightly higher in some studies. And the disadvantages is that today there's still minimal third-party studies measuring rates of fusion. So what is the evidence? And so I kind of want to pause here because there's a lot of, when you look at these different studies, there's very different ways of how people assess fusion. When you talk about what is the gold standard for assessing arthrodesis, is really just to re-explore and to visually confirm that you have bridging bone, right? But that's not feasible for a study, especially if you're going to do in a clinical series. So you're left with some sort of radiographic confirmation. Now, in a number of studies, just flexion extension X-rays without movement is considered enough for a fusion. But we know that if you have a stable pseudoarthrosis, you're going to have a false positive rate in terms of arthrodesis. And then maybe a more sensitive way is using some sort of three-dimensional image like a computed tomography. But there's some challenges there because especially with some of the newer implants that are made of titanium, there's quite a bit of scatter. So it can be hard to discern some bridging bone when you're looking at the images here. So I think this is something that's important to keep in the back of your head whenever you read a study about any sort of arthrodesis rate in a biologic. So here I was going to present a little bit of a systematic review that my resident Edwin Talemi and a few of our medical students were invited to comment on osteobiologics for MIS TLIF for the International Journal of Spine Surgery. So the methodology here, we did a PubMed database criteria that's referenced single-level TLIF, transfemoral fusion, and any of the following: graft, autograft, allograft, biologics, bone morphogenetic protein, ceramic, demineralized bone matrix, mesenchymal stem cells, and autologous growth factor. So we picked MIS TLIF because, if you think about, again, going back to the burden of arthrodesis, the TLIF inner body is probably your, for lack of your better term, the least desirable in terms of getting arthrodesis with your graft window and kind of the access to the disc space and how much disc prep you can have. So, things like A-lift, things like lateral, these all have large footprint cages where you have significant graft windows and you get great access to the disc and disc removal. So if you're able to get a good fusion rate in an MIS TLIF, then the chances are the biologic is probably fairly robust. So additional inclusion criteria, we looked at studies with reported fusion rate, complication rate, patient-reported outcomes, and it had fusion rate at least 1 year post-operatively. So here's a summary graph. If you're looking at this on the video, you can pause this and zoom in. Number of studies. Just wanted to go over kind of all the different studies quickly. So autograft, again, this is the gold standard when we're talking about iliac crest bone graft. So you have 364 patients across 6 studies. Your fusion rate ranges anywhere from 76 to 100%. And like we alluded to earlier, your highest complication rate was associated with those using iliac crest bone graft, where you saw about almost a third of patients with harvest site pain. And I'd like to say fairly high wound complication rates, 6.1% wound infection, 3.1 and 4.2% harvest site infection. So, if you think about MIS TLIF infection rate, it's a fraction of a percent. So if you're introducing a harvest site infection rate on top of that, then you're losing some of your benefits of the minimally invasive approach. Allograft, 3 studies total, 726 patients. Only 1 study reported a fusion rate, which is kind of interesting when you talk about grafting studies. This is, again, you have to be buyer beware in terms of when you review the literature. But the 1 study reported a fusion rate of 96%, which is pretty good. 4% pseudoarthrosis in another study. So bone morphogenic protein, or recombinant human bone morphogenic protein number 2. So this, again, there's no osteoconductive properties to BMP, so you have to couple this with something to supplement. So either with an allograft or a local autograft. So you have fusion rates anywhere from 78% to 95.8% here. There was also a fairly high complication rate with the autografts, about, again, 27 to 29%. Heterotopic ossification was reported in about 13.5% in 1 fairly large study of 867 patients. And then there's you have other complications including postoperative radiculitis and vertebral osteolysis as well. But relatively at a low rate of pseudoarthrosis, about 2.5 to 2.6%. So getting into the DBMs, only 3 studies, 168 patients, only 1 study reported a fusion rate of 92%. Ceramics, again, you have to use this in combination with something else that's osteoconductive. 2 studies, 112 patients total, fusion rate between 91 and 93%, and then used in combination with autograft. What we didn't include in that review was the cellular bone matrices. So here I've referenced this paper from Neurosurgical Focus, where they actually did a PRISMA review looking at these bone matrices. So after exclusion, there was 13 human studies total. 5 were cervical, 8 were lumbar. 2 studies actually compared the cellular bone matrices to BMP without any statistical difference in the fusion rate. And the overall fusion rate was reported between 90 and 98.7%. And with this study in particular, the authors commented it was really difficult to ascertain the additional efficacy of the cellular component with non-biased third-party studies. So many of these products, they have some data to or some literature to kind of back up their claims, but again, this is not verified, independently verified with a third party. And then really the question is how much of the arthrodesis that you're seeing from these types of products is just from the DBM component that comes with the graft. And then when you compare the costs, oftentimes per CC basis, there's almost an order of magnitude in difference in terms of costs. So really, especially I think in this healthcare environment, as surgeons, we have to weigh the relative costs of different products with the value and efficacy that we get. But wait, there's a few more things to go over. So other emerging products, and again, don't believe anything I say because I'm a consultant, but OsteoAMP, AMP. So this is a differentiated allograft with some unique processing design. So it retains a number of growth factors as well as some vascular growth factors like VEGF and angiotensin 1. This was a pretty interesting study from Jeff Rowe and his group. I think it's a fairly robust study design where they compared patients using both BMP and OsteoAMP, and they had actually a third party, they had an independent radiologist who was blinded to what treatment the patients received, and they used CT data to look for arthrodesis. And he measured, in their study, they measured the rate of arthrodesis at different time points up to, I think it was 2 years after surgery. So in general, they found that with the OsteoAMP, there was a higher rate of arthrodesis, and then there was a kind of an accelerated of arthrodesis compared to the BMP. So again, there was kind of some weaknesses or some caveats of the study, I should say. There was significant heterogeneity between the cohorts. So as far as I could tell, this was just a univariate comparison. So there wasn't any sort of multivariate regression, to correct for co-founders. But nevertheless, I think it's an interesting study. And then the final study or product I wanted to highlight is iFactor. So this is an older study published in IJSS. So the iFactor, again, it combines a natural defect hydroxyapatite with a synthetic 15 amino acid chain polypeptide. And this acts as an attachment factor for osteogenic cells. So this is actually the history of this product. It was actually FDA approved for dental applications, but I think they found maybe some value in spinal fusion surgery. So in this particular study, they did a PLIF, which like an actual real old-fashioned PLIF where you had 2 cages side by side, and one of the cages they filled with autograft, and the other cage they actually filled with iFactor and autograft. And it's interesting looking at the study because they'll show you the CTs where you can see on one side you have the cage fused with the iFactor, and the other side you don't see the bone quite as well. So it's almost like an internal control where you're controlling for the patient biology in itself. So, but nevertheless, even within the autograft, you still saw a 93% fusion rate compared to 95% with the iFactor. So, as far as obviously, the one thing you have to keep in mind is there may be some reporting bias, but generally speaking, you don't see anything reported less than 90% in a lot of the current literature. So in summary, there's a wide variety of options available for arthrodesis and minimally invasive spinal fusion surgery. I think we have to be cognizant that the reporting on efficacy is variable and comparative studies are few. And then the final thing to keep in mind is I think cost should also be a factor when we're selecting our products for arthrodesis. So with that, thank you for your attention. I'll open up to any questions.
Any result or any new knowledge about mixing stem cells like bone marrow or even spinning and collecting more stem cells and mixing with any of this biologic?
Yeah, so I kind of glossed over it. With the mesenchymal stem cells, we did find some studies in the review. And, this was harvesting from like abdominal fat, things like that. I don't think they saw any additional efficacy based on that form of harvesting. I mean, theoretically, from a biologic standpoint, it sounds like it might be a good idea, but I think maybe the implementation is not quite there with this.
If I may just have No, I'm specifically asking, for a while it has been this system that you take either bone or bone marrow, and then you spin it, and then collect and concentrate the stem cells. But I myself only just use from my Jamshidi, take the bone marrow from the vertebral body. Any follow-up study on that you are aware of?
Not within for TLIP, not that I'm aware of, yeah.
Thank you.
Hey, Vic, thanks for giving that talk. A lot of these vendors will quote the concentrations of growth factors that their product has, indicating that theirs is twice as much as their competitors, therefore it's better. But at some point in time, there has to be a threshold beyond which it doesn't make any clinical difference, right? Has that been established for any of these growth factors? That's like part one, and part two is how much of those things are viable when you're actually putting them in?
Right. I mean, I think it goes back to you have to understand kind of the regulatory mechanism for some of these grafting products because they're the 410K, so there's not any independent testing that has to be, that the FDA mandates that you have to demonstrate when you bring your product to market. And so I think, the barrier for entry is fairly low, and then you can say whatever you want. With your own, I mean, I don't think people are intentionally being misleading, but again, all of these processes for harvesting things like cells and growth factors are proprietary, and really you don't have a great way to independently verify beyond what the company is telling you. So.
Yeah, I mean, Osteobiologics is a big business nowadays, right? I mean, multi-billion dollars, and I know institutionally millions of dollars. So, I mean, really, I think increasingly it's going to come down to data, evidence, and cost, obviously. I think we're going to have a longer discussion, but we're a little bit behind, so we're going to transition to the